All right, thank you. Very comprehensive and insightful. You've gone a very long way down this road, it sounds like. And so, Adam, last but not least.
Well, thanks for the opportunity to be here. Excited to hear everybody's perspectives and tell you a little bit about what's been going on at Geisinger. Just a bit of background, although Geisinger just rebranded from Geisinger Health System to simply Geisinger, because I thought the brand was that strong. In case people aren't aware, we are in central Pennsylvania with a largely rural population of around 3 million or so that we reach in our catchment area. And that's a very stable population in terms of families of multiple generations living there. But it's also a population that has several regions that are medically underserved with higher levels of comorbidities among patients that come to see us, a little bit older than national averages, lower income, and some other socioeconomic challenges. So about 10 years ago, that setting was seen as a really prime for doing some genomics research and discovery research particularly, and a program called MyCode, the MyCode Community Health Initiative, was begun then. And over time enrolled and looked for drug discovery and other discoveries to match up with electronic health records, which Geisinger has had for about 20 years now. As a lot of the folks in the room are involved in conversations and national conversations about returning research results and what to return with genomic results in 2012, 2013, and so forth, we were paying attention to those conversations and involved in them as well. And went back to participants, clinicians, other stakeholders, and said, well, we have genomic information on the folks within this cohort now. Do we have a duty to return at least some of that? And if so, what shape should that take? And what we ended up with was a lot like what's been described already, medically actionable conditions, where we are returning pathogenic or likely pathogenic variants, the high penetrance, high impact on both patients and their families, and that we would do so in a way that engages the participants and their clinicians as well, so that there's a supportive infrastructure built around it to help the patients understand what that result is and incorporate it into their care, but also to try to support the clinicians, knowing how challenging it is to carry on the rest of what they're required to do. So that effort of planning to return genomic results was facilitated further by collaborating with Regeneron Pharmaceuticals in 2014, which allowed the participation in MyCode to ramp up to its current state, which is about 162,000 participants, with about 90,000 of them who've had whole exome sequencing. And we started returning the genomic results that is a very similar list to what's being returned through eMERGE in 2015. So we've been doing this for a little over 2 years now. We've returned a result to a little over 400 participants. And because we're a health system that values a learning healthcare system approach, we've been tracking outcomes there and trying to understand how this information is being incorporated into care, what are the reactions to it from those patient participants, how are the clinicians reacting to it, is this as valuable as we thought it might be as genetics folks, and where does this really fit in terms of everything else that's going on in the patient population. So we've had I think some early successes. In those couple of years, we found a few people who had occult cancers that were diagnosed because they had a return result in a BRCA1 or 2 variant. We have done some qualitative work to look at some psychosocial outcomes related to getting a result, and have found that for the most part, people are adjusting well to this information. It's certainly a surprise, but this is a different way of finding out genomic information from the typical way of a person being identified because of a personal or family history, and having some level of investment in finding out the genomic information. For some people, we are calling them out of the blue and giving them information, and that leads to an initial surprise, particularly when there's not a family history that appears consistent with it. So in spite of that surprise, we've been pleased to see that the adjustment to it has been favorable, and that some of the other things that one would hope would happen if you return a result have happened. So things like communicating results to relatives to try to facilitate cascade testing among relatives, beginning to use the information to guide care and adopt risk-reducing behaviors. We've seen some of that happening too through our qualitative work. Just a little bit more about how we do it. It's kind of a stepped process of a return. So we valued engaging primary care clinicians as well, and got feedback from our clinical oversight committee that that's where we should start with a return, to give those clinicians who have the long-standing relationship with their patients an opportunity to have that discussion first. So once we get that PDF result back from the laboratory, which is a CLIA laboratory, then that's uploaded into the electronic health record. We send a notification to the primary care clinician, and then give them about 5 days to have that discussion with their patient. Then we start contacting the participants themselves with a kind of an increasing level of detail about what that information means. So first is a written contact, which says basically, do you remember when you signed up for MyCode, we told you we'd tell you if anything important came back? Well, it has. Please call us. So nothing about the result itself, just an invitation to call and have a conversation. Then if they don't call back, we start calling them. When we have someone on the phone, we'll describe in a scripted manner what that results means briefly for their healthcare and their either cancer or heart disease risks, and then encourage them to follow up with the clinician that they're most comfortable with. That can be our clinical genomics crew, it can be their primary care clinician, or sometimes it's a specialist. And then we'll try to coordinate that care that follows up after that. We have seen that about half of the people that we disclose a result to want to come see us in genomics. About a quarter want to see their primary care clinician. And roughly a quarter say, thanks for the information. Either I already knew that because I was tested clinically beforehand, or I think I'm good and I don't really need any further support. So some of the challenges that we've seen include that ones that have been mentioned already. You know, how do we incorporate this into care that's already complex for a lot of people? How do we support clinicians who are very, very busy and have other things that they're required to do? And how do we make sure that we're following folks longitudinally, which we don't always do that well in genetics, and keeping up with recommendations for care as they're changing and really having an engaged group over time. So speaking of time, looks like I'm out, so I'll stop there.